So, cardiac muscle disease, part 3 of congestive heart failure. This series is going to cover the treatment of congestive heart failure and the physical therapy evaluation and interventions. So, let's start with medical treatment. The goal of medical treatment is to reduce the workload of the heart. We've talked a lot about how hard the left ventricle has to work when we have left-sided heart failure, and what can happen if it is working too hard. We've also talked about the work of the right side of the heart, trying to push blood into the pulmonary artery and into the lungs. So if we're going to reduce the workload of the heart, we can do two things. We can either decrease the preload. If you remember, the preload is the amount of the tension on the heart muscle before contraction, and we can think about preload, the measurement of preload, as the amount of venous return back to the right side of the heart. We could also decrease afterload. Afterload is the pressure with which the heart has to pump against in the arterial system. So we can either work on the preload component or the afterload component. When the medical team treats congestive heart failure, one of the main things that they'll do is to work on dietary changes. So dietary changes, we think about limiting how much fluid you drink. Okay, so when we have lots of fluid, we can increase the volume in our vascular system. Limiting how much salt you have. If you have a lot of salt, you tend to hold on to fluid. So those are two big things that we can do. From a pharmaceutical standpoint, we're going to try to either control fluid, blood pressure, or provide oxygen. So if we try to control fluid, the physician could provide the patient with a fluid restriction, or they can give the patient some sort of diuretic to try to pull fluid off. Remember, the kidneys have a big part in managing the level of fluid in the body. We could try to control blood pressure. So if we control fluid, remember we're sort of controlling that preload and that afterload. If we control blood pressure, we're mostly working on controlling the afterload. So medications to lower blood pressure like atenolol or lisinopril, these medications are going to decrease the blood pressure, thereby decreasing the workload of the left ventricle. We can also provide supplemental oxygen. So why would supplemental oxygen be beneficial for patients in congestive heart failure? Well, if the right side of the heart isn't getting blood into the lungs to do perfusion, right, to let off CO2, to bring in O2, if that's not working very well because of pulmonary edema, then the blood that the left side of the heart is pushing out is not very oxygen rich. If you don't have oxygen rich blood, then the myocardium is not being fed. So we're going to have we could have ischemic changes in the myocardium of the heart. And the rest of the body is also going to demand the organs, brain, kidney. These organs are also going to demand oxygen. So providing supplemental O2 increases the amount of oxygen available in the lungs. So when that smaller amount of blood comes in to be perfused and to pick up oxygen, there's more oxygen available. So it makes that process more efficient. So any of these things, as pharmaceuticals, can decrease the workload of the heart. So another way that we can decrease the workload of the heart, and you may recognize this picture, this is that intra-aortic balloon pump. So what the balloon pump does is the balloon pump can decrease afterload. So during systole, the balloon is deflated so that as the ventricle squeezes, there is no resistance against the pumping mechanism. But during diastole, the balloon is inflated. So as the ventricle squeezes, it is pushing against the volume of blood that is still in the aortic arch, not against the total peripheral resistance. So this can help make the heart more efficient. It also can increase myocardial perfusion because the heart is fed during diastole. So for a short-term fix of for severe acute congestive heart failure, you may do an intra-aortic balloon pump. Remember, there are lots of things that go along with that in terms of what mobility limitations that we have. Now, you can do an orthotopic heart transplant. Orthotopic means we take the organ out of a body and we put it into a different body in the same orientation without removing anything from the organ. You may say, gosh, why would you remove something from the heart before you transplanted it? This term is mostly you'll see orthotopic liver transplant versus a liver transplant where someone gets just one of the lobes of the liver. So orthotopic heart transplant can help to treat CHF. How does this work? Well, if we think about some of the causes of CHF, either a non-compliant ventricle or a hypertrophied ventricle, we can remove that problem and instead put in the heart transplant with ventricles that are not hypertrophied. Now, the same things that cause the hypertrophy in terms of blood pressure, those could still be present, but if patients had an MI and they either have a dilated cardiomyopathy or they have scarring in the tissue, those are going to be eliminated. The heart transplant is a big deal. The number of hearts available has slowly decreased over time, and a lot because the fewer people are dying in traffic accidents. The number of people that need a heart transplant continues to increase. And that's going to take us to the LVAD, but we're going to talk about that in just a second. Dialysis is another way that we can help to treat acute congestive heart failure. And we can do that because dialysis is doing the work of the kidneys. And when the blood is removed from the body, is filtered and then put back in the body, they can actually pull fluid off. So you can decrease the fluid volume during dialysis. So this will help to decrease both the preload, the amount of venous return, and the afterload, the amount of, it could have some effect on the afterload because it is decreasing the total volume, which should decrease the total peripheral resistance somewhat. So in the next slide, we're going to look at LVADs. So LVAD is a left ventricular assist device. This device requires a median sternotomy, so it's a pretty big surgery. There are two reasons to put LVADs in. One would be a destination therapy. That means that's the end of it. There's no other goal. And the other would be a bridge to transplant. In either case, we put the device in the same way. You can see in the image, part B, or picture B in this image, the LVAD pumps blood into the aorta. So it pulls blood out of the left ventricle, it goes through a centrifugal pump and pushes blood back into the aorta. Now, sometimes they'll actually stitch the aortic valve closed so that you make sure that all of the blood in the ventricle is going to go through the pump. But oftentimes they'll leave that open so the body is doing some of its own pumping, but mostly the LVAD is responsible. The LVAD has to be powered. Okay, that pump has to be powered. So that power, if you notice on B, there's from the pump there's a little cable connecting to the control unit. It's kind of going down, and you can see how that cable goes through the abdomen and then to a system controller or control unit on the outside. And that control unit is powered by batteries. So on the next slide here, we can kind of see real-life versions of this. So the picture on the left, the gentleman has showing the control unit, and actually this is an older model. The newer ones are a little bit smaller and have a screen, a touch screen that you can manipulate to kind of get some more information about how the unit's doing. But the basic concept that control unit is attached to you constantly. If that control unit is disconnected, the pump stops and then your heart stops. If we look at the picture to the top right, you can see the two batteries that are connected to the control unit. The control unit always is powered by two different sources simultaneously, because again, if the the control unit loses power, then the pump stops and the heart stops. The picture on the bottom right shows all of the accoutrement that you need in order to maintain this pump. So on the right side of this picture, you see the charging station with 2 batteries being charged and 2 other batteries on the table that the patient is ready to connect the system controller to the battery. On the left side, you see the base unit. This is the unit that is plugged into the wall, and when the batteries are not being utilized, you plug the system controller directly into the base unit, and then you are tethered to the base unit. In which to really think, we've talked about some people not wanting to take Coumadin because they can't leave town for a long time, their diet is restricted, they've got to get their blood, they can't leave town because they have to get their blood drawn regularly. And then you think about the extent of an LVAD, where you are tethered literally to that base unit or to the batteries, and the batteries they say last about 10 hours, but really they encourage you to change them after about 6 hours. So that means that you may be able to drive to Chicago, but you might have to stay the night somewhere if because you always want to have 2 batteries that are fully charged. So if you think about a 6-hour radius, and think about how much that limits you, and that's after you're fully healed and kind of ready to move on. So that's for destination therapy. The bridge to transplant, you may have a patient who is not going to survive waiting for the transplant. So they'll put an LVAD in, and then when the heart becomes available, they'll take the LVAD out and put the new heart in. So next we're going to talk about the PT eval. So the diagnoses that you may see, you typically are going to see the phrase congestive heart failure, or you might see heart failure, or it might give you a description exactly of what it is. So you might see left heart failure, right heart failure, a systolic heart failure or diastolic heart failure. And you may actually see a phrase such as heart failure with preserved ejection fraction. So HF, little p, big EF. Or heart failure with reduced ejection fraction, big H, big F, little r, big E, big F. The diagnosis could be LVAD or orthotopic heart transplant. And sometimes you're going to see other diagnoses that are really going to lead you to, you're going to find out eventually that heart failure is playing a big role. For instance, a patient is admitted for renal failure. A patient has a cardiac myopathy. They probably have some component of heart failure. Patients with valve disease typically have some component of heart failure. And many times, a patient who comes in with lower extremity swelling or lower extremity edema, there are a number of diagnoses they could have. It could be some COPD, it could be DVT, it could be cellulitis, but many, many times it's going to be congestive heart failure. So these are patients who have difficulty with venous return. In the chart review, one thing you might look at are radiological findings. So chest x-ray would be a good example of this. So you might see that the size and the shape of the cardiac silhouette, the heart may be larger than normal due to that hypertrophy. You may see words like interstitial or perivascular or alveolar edema. These are all things that are hallmark signs of congestive heart failure on a chest x-ray. And then atelectasis, so collapse of lung segments, either lobes or smaller segments like groups of alveoli, could also be present. We talk about lab findings. You may find markers of renal failure. So increased BUN or increased creatinine levels could be a sign of renal failure, which is a component of most heart failures. O2 saturation levels could be decreased because we're not perfusing very well, getting new oxygen into that blood, and CO2 levels could increase because you may not be ventilating very well. You may not have enough. You may not be filling the lungs up enough to do that diffusion and get the CO2 out. And many times there are electrolyte imbalances in chronic heart failure, and that's because you have so much volume, so much blood volume, that the kidneys may not be functioning well enough to pull volume off and pull some of those electrolytes out to get a good balance. Other lab findings, and this is a new lab value we haven't discussed yet, and that's the BNP, the brain natriuretic peptide. So BNP is actually a measure of heart failure. So a value of 0 to 99 is normal, and a value greater than 100, or 100 or greater, indicates heart failure. Now, is this an important value to know? Is this something that you would write down? I do typically write it down, especially if the patient is admitted for an acute exacerbation of heart failure. Now, is there a cutoff when I don't see a patient? There's no cutoff. The higher the number, the more severe the episode of heart failure is. So I use this number not to decide if I'm going to see a patient or not, but rather to kind of plan out what I might do with the patient. Much like a low ejection fraction, the patient may have decreased tolerance to activity. A high BNP is going to tell me that their symptoms that come along with heart failure could be exacerbated. That lower extremity edema, that shortness of breath, increased workload of the heart. So I'm going to keep that in mind as I prepare to see the patient. But I do write that down in the hospital course. NT-proBNP, this is another indicator of heart failure, much like BNP. The norms vary by age. They're not really any established norms. There are a number of journal articles that discuss what the expectation is for different age population. But this number, if I don't see the BNP, I could substitute the NT-proBNP. Now, the troponin I levels, so this is the troponin, the regular troponin we've talked about, it might be elevated in heart failure. So what do we do in that point? What if the cutoff level for troponin is 0.05? What do we do if a patient with heart failure has levels of like 0.7, 0.07, 0.08, even 0.1? What's causing that? Because we think about troponin levels as being the sign of ischemic disease, so heart attack. We need to remember that when the workload of the heart is increased, if it's not getting the oxygen that it needs, if the oxygen available is not meeting that myocardial demand for oxygen, then you have ischemic changes in the heart. So a slightly elevated troponin, slightly positive troponin, that it isn't really trending up or down, and could be a sign of heart failure. So if I have a troponin level that is not really trending up or down, it's just a little high, and they also have maybe a positive BNP, or they're being worked up for acute exacerbation of heart failure, I tend to say, this is a good thing to write down. This number is telling me about the workload of the heart and how it's tolerating it. But I don't use the troponin level to stop myself from treating the patient. It's a little confusing, so you might need to back up and listen to it again. But those three lab values are pretty important when we talk about heart failure. Now, this is the New York Heart Association Functional Classification of Heart Disease. I am not going to ask you to regurgitate for me the description of each class of heart failure. Note that Class 1 really has no physical limitations, and Class 4 is unable to carry on any physical activity without discomfort. Heart failure happens at rest. Now, many times patients are being worked up for an LVAD or a heart transplant at Class 3. At Class 4, the patient is really sick, and they may not be able to tolerate the surgery or the rehab after those major surgeries. It does not to say that a patient with Class 4 can't qualify for those surgeries, but if you really think about that description, unable to carry on any physical activity without discomfort, what is their rehab expectation going to be? What is their rehab prognosis going to be? Excellent? Maybe not. So the important thing to know here is that 1 is pretty healthy, 4 is really not healthy. And you may be lucky enough to see the the New York Heart Association classification in the chart review. That'll give you a lot of information about the patient's baseline or prior level of function. Now, in the interview, discovering the prior level of function is really, really important. Okay. Also noting the onset of symptoms. Like, is the first symptom lower extremity swelling? Is the first symptom shortness of breath? Is the first symptom ascites in the belly? In your education, this could help to talk to the patient and say, hey, if you have lower extremity swelling, it would be a good idea to maybe call your doctor and let him know. So it's that sort of preventative medicine. Heart failure is a preventative disease. And we'll talk about that later with the education. But there are 5 things that a patient can do. And if they do all 5 of those things, then they shouldn't have exacerbation of heart failure. The last thing on here is orthopnea. Orthopnea is difficulty breathing when supine. One other thing, this is measured, literally measured in the number of pillows that you sleep on. It would be great if we could measure it on an angle, right? The angle of the head of the bed. But most patients have regular flat beds at home. So patients will say things like, I have to sleep on 3 pillows or else I can't breathe. And in the chart, you may find in the chart review, patient has 3-pillow orthopnea. Now, does that limit us from treatment? Not at all. But does it give you an idea of positioning the patient for comfort? It really does. It might be good to try to get the patient out of bed with the head of the bed flat, because that's the kind of bed they have at home. But a patient with 3-pillow orthopnea doesn't ever lie flat. It's also important, if you think about repositioning a patient in bed and scooting a patient up, we typically lower the head of the bed flat, and then we scoot the patient up in bed. With this patient, we need to really limit the amount of time that they're flat, because they're going to feel like they can't breathe when they're low. What time of the year is this patient admitted? All year round, okay? Especially times when people tend to eat extra salty foods and consume more alcohol. So around holidays I sometimes see this, and quite a bit in the winter months as well. Okay, what are we going to observe? What kind of findings are we going to have? Well, the picture tells us one. That's a picture of jugular venous distension. So that's actually the jugular vein that you can see right there, and you can see it kind of popping out. That is a hallmark sign of heart failure. And one thing we might also observe is decreased activity tolerance. So the patient needs lots of rest breaks. The patient has peripheral edema. And we can actually measure peripheral edema. We can use the Pitting Edema Scale. We're going to talk it, like that's how you would document it. You would say patient has peripheral edema, and then you could describe where it is. You could even say patient has pitting edema of this much, 2+, 3+. The 2 sort of tests that we do to measure activity tolerance, and these are pretty standardized tests. One is the 6-minute walk test. There's a lot of normative data for patients who have heart failure. So you ask the patient to walk for 6 minutes. You try to make it into a circuit so they're not pacing back and forth. The patient can stop and take a break however they want, but you measure their distance walking over the course of 6 minutes. The other one is the rate of perceived exertion scale, so the Borg RPE. The Borg RPE is measured on a scale of 6 to 22. It seems like a weird set of numbers. The reason it's measured on 6 to 22 is that if you add a 0 to the number, it should give you their patient's approximate heart rate. So 6 would be 60 and 22 would be 220. Like we said, patients are on medications a lot that are going to help to decrease maybe their heart rate, decrease their blood pressure. These patients a lot of times are on beta blockers, and we have a blunted heart rate response to these on these medications. So the Borg RPE is a way to gauge their intensity of their work without in a way that is functional for patients like this. We want patients to work when they're doing aerobic activity. They should be between an 11 and a 13 on the Borg RPE. Another thing that we're going to be able to observe here is the heart rate and heart rhythm. So patients a lot of times have maybe a sinus tachycardia. So there's not enough oxygen in the bloodstream, they have extra fluid volume, so they start to increase the heart rate to try to move that fluid around, and also to get more oxygen to the skeletal muscles and to the heart. Now, we haven't talked about heart sounds in depth yet, but there are 4 heart sounds: S1, S2, S3, and S4. S1 is lub and S2 is dub. Those are normal heart sounds. S3 is the hallmark of CHF. S3 happens just after, I think S3 happens just after S1. You hear S3 the best when the patient is laying on their left side. Now, S4 is another heart sound that you can hear in heart failure. S4 heart sound is the sound of a non-compliant ventricle. Okay, so we hear these abnormal heart sounds, and you can actually use that, especially S3, as a measure of the patient's tolerance to your activity. I've had patients who have, I hear, before I work with them, I listen to their heart sounds, and I hear S1 and S2, and after working with them, I hear S3. Now what that tells me is that I pushed the patient too hard. The intensity of the activity was too great, and I have put them into a little bit of exacerbation of heart failure. So you shouldn't hear S3. You don't want to hear it. In the best case scenario, you hear S1 and S2, you treat your patient, and at the end of that, you hear S1 and S2 again. Now, in the assessment, we need to identify their impairments, identify the rehab potential, and identify their therapy tolerance. So the impairments are typically going to be limited mobility due to dyspnea on exertion. You may have limited mobility or limited functional mobility due to peripheral edema or abdominal distension. The rehab potential for these patients is actually pretty daggone good, especially if there's appropriate medication and dietary restrictions are on board. Their tolerance to therapy is not great. Okay, we're going to use the Borg RPE as a way to measure their therapy tolerance, and we are also going to build in lots of rest breaks for these patients. Okay, we don't want them to do activity that is so intense that it compromises their ability to continue to work in an aerobic way. Which impairments will physical therapy address? Well, whatever functional impairments we need to do, first of all, to get the patient home. And secondly, there's going to be a lot of education with these patients, because we are going to need to be a part of the team that is educating them so that their heart failure is not exacerbated again. So discharge planning, the goals for this patient there's going to be goals for activity tolerance. We don't use the word endurance. We need to have something that is measurable. So you might say patient to ambulate, let's say on the evaluation they were able to ambulate 50 feet with 4 rest breaks with an RPE of 13. Or we might say the patient will be able to walk 50 feet with no rest breaks with a RPE of 11. That would show us, there'd be a lot of different things we can measure there in terms of intensity and the amount of rest the patient needs to be able to continue the activity. Equipment, a lot of times these patients, we will give them a rolling walker. It lets them to stabilize distally so that they can use their accessory muscles to breathe, because that can help with ventilation and perfusion. So something to consider for these patients. Discharge location recommendations. This is always a tough one. These patients are going to be mobile enough to go home, but in terms of their endurance, they may not be able to cover the distance or do things in a timely manner in order to be able to go home. So you may really have to think about What are the benefits of going to a skilled nursing facility? Sometimes I can get these patients into inpatient rehab for a very short stay in order for them to do some sort of functional activity, especially if the patient can't do stairs. And if you go up 2 flights of stairs right now, you may be a little bit short of breath, especially if you go up quickly. If you think about these patients, 1 or 2 steps, they may need a break after just 1 or 2 steps. Therapy recs after DC? Well, these patients don't typically need outpatient PT. Sometimes I will encourage home health PT so that the PT can maybe look at the house. They can help to make it their flow of their day more efficient. And these patients might not be able to do aerobic activity, like they may not be able to walk 30 minutes a day. So having that home PT check in for a few weeks to help increase their activity program, increase their walking program in a way that is safe and not going to put the patient back into heart failure could be really beneficial. Now, readmission penalties. This is something that is a newer thing that hospitals have found, that for patients who have preventable diseases, if they are readmitted to the hospital, then the hospital does not get reimbursed for that second admission, and heart failure is considered a preventable disease. So there is a big push to do education and good treatment with these patients in order to prevent that readmission. We don't want the patient readmitted in 30 days. Okay, position of the patient. How do we do TheraX with these patients? Do we do it sitting up? Do we do it supine? Take a second to think about that. So the best answer for these patients is that we want to do exercises in supine. When we have in sitting up, either standing or sitting, erect. When we do that, we decrease the venous return. We decrease the preload. We give the right heart a little bit of a break. The problem is that we can't leave the patient sitting up for a very long time because they don't have a lot of venous return, and they get a lot of peripheral edema. And that is uncomfortable. When you have a lot of peripheral edema, you're at more of a risk for cellulitis. So we need these patients to exercise upright with their heart above their lower extremities, but we don't want to leave them there for very long. So I typically will tell a patient, I want you to sit in the chair, but only for about 30 minutes. And then I want you to get back in bed, and I want you to sit with the head of the bed elevated, but your legs straight out, so your feet aren't on the floor. Now, with patients who have end-stage left heart failure, formal exercise can actually deteriorate function. End stage means it is the last stage. It is the patient is not going to die right away, but their heart disease is going to be the thing that is going to kill them. Their heart is failing, and it's not going to get better. Formal exercise can deteriorate function because you could be pushing the heart in a way that it's not going to be able to compensate for. So with these patients, I typically have them do activity to their tolerance. So I might give them some leg exercises. I may give them a walking goal, like you can walk from here to the bathroom 10 or 15 feet, and then rest for about 5 or 10 minutes, and then come on back. We want to keep them moving, but we don't necessarily want to say, I need you to walk 30 minutes a day, 6 days a week. It could be too much. Now, with mild to moderate heart failure, what we find is that they do have some limited exercise tolerance, but with some sort of low-intensity aerobic activity program, their central hemodynamic response is improved. So their ability to compensate and tolerate that heart failure is better. So I typically start them off on a walking program based on their RPE only. Okay, so I might say, I want you to try to walk for 7 minutes total today, maybe in groups of 2 or 3 minutes, but I don't want your RPE to ever get over 11. I don't want your RPE to ever get over 12. That gives them a lot of control and a lot of ownership of the program. And I tell them, if you can't do that much today, that's okay. That's okay. And some people, it's not even a walking program. It might be some sort of low intensity active range of motion, not resistive, but just active range of motion. So because that might be enough of a challenge for their heart that it meets our goals. Okay, education. This is a big component. Remember, I told you there are 5 things that if the patient does, they would never have to come back for heart failure exacerbation. One thing is daily weights. So if the patient weighs himself every day, we're looking for them to if they gain more than 2 pounds overnight or more than 5 pounds in a week, that tells us that they're holding on to too much fluid. At that point, they need to call the doctor and maybe have an increased dose of their oral diuretic, or they may come into they may see them for some sort of IV medication. They need to take their meds. They need to take their meds every day. You know, with this population, one of the things that we found is that sometimes the amount of medication they're on is more than they can afford. So being a part of the team that reminds the patient to take their medicine and to ask the doctor if they need assistance is really important. They're going to limit their fluid intake. The physician is going to give them a fluid limitation, and many times it's about 2,000 mLs a day, or 1 2-liter bottle of fluid all day. And that includes, if they have soup, that's fluid. If they have water, that's fluid. Jello is fluid. So they're going to have to really watch their fluid intake. They also need to limit their salt intake. And the salt limitation is a pretty severe limitation, tends to be. The last thing is to do some aerobic activity. So for patients who can tolerate it, to do 30 minutes of aerobic activity a day is really good. Okay, we can help them lose weight. That's going to decrease their afterload, and we can help to make the heart a little bit more efficient. Now remember, if a patient can't tolerate that much activity, we need to tailor the activity recommendation specifically to them and their level of function. So the other part of the education, that exercise prescription, we need to help them be very familiar with the Borg RPE, because that is the way that we're going to teach them all the time. Now, there is a modified Borg RPE. It's a 0 to 10 scale. I think some patients find it easier to utilize that scale. And on that scale, we're looking for them to try to maintain a level of 2 to 3 during their aerobic activity. Now, the ejection fraction, it's something to keep in mind when you're looking at exercise prescription. These patients typically, a lot of times they have a reduced ejection fraction. So this is going to kind of tell us that their cardiac output might not be normal. So they're going to fatigue more quickly on top of everything else they're dealing with. So patients with a low ejection fraction, be very careful with the intensity of activity that you provide. Much like the ejection fraction, looking at in the acute care setting, looking at how high their BNP is could tell us about the severity of their exacerbation of heart failure. So a patient with a higher BNP might need to start off with a lower intensity exercise program. And remember too that their cardiac output, while we are not going to directly measure their cardiac output, if their ejection fraction is low and their cardiac output is low, which is very possible, right? We talked about valvular stenosis, we've talked about an incompetent valve, we've talked about left ventricular hypertrophy, changing the stroke volume. These are all things that are going to affect cardiac output, and a patient who has a low cardiac output is going to need to start off with a lower intensity exercise program. So these programs, there's not a one-size-fits-all program for heart failure patients. It needs to be pretty specific. Now, if a patient is an uncompensated heart failure or decompensated heart failure, it's uncontrolled, they're very dyspneic, they might not be able to start activity. If a patient is in decompensated heart failure, and that sometimes is in like the first 24 hours after admission, they're not appropriate for therapy. They're not appropriate for aerobic training. Sorry, they may be appropriate for functional mobility, but they're not appropriate for that aerobic training that we're trying to teach them. When it's medically managed, when it's compensated, we can begin aerobic training, and it's safe to do so. Because these patients can can change, their tolerance and their stability can change very quickly, because we can burn up that oxygen that they have in their system very quickly and they can't keep up. We need to monitor these patients very closely and continuously. We monitor the patient, we can monitor their heart rate and blood pressure. Remember, their heart rate sometimes is not the best measure. Blood pressure may be artificial too, depending on what kind of medications they're on. We can measure their respiratory rate and their oxygen saturation. And as long as the patient, oxygen saturation is really good as long as the patient doesn't also have obstructive pulmonary disease. Respiratory rate tends to be pretty good if the patient has healthy lungs. Now we can auscultate the heart and the lungs. This is going to be important to do. If we get that S3 heart sound or we hear crackles, that's going to tell us that we might be pushing too hard or their tolerance might be poor. We may hear crackles, remember, because we're talking about if fluid is not getting past the left ventricle very well, it's going to back up into the lungs, and we have that pulmonary edema, and that's where we get the crackles. So the Borg RPE is another way to monitor the patient. And if they really just can't understand that scale, one of the best ways to educate somebody on what is aerobic activity, they should be able to talk during exercise. Okay? If you cannot talk during exercise, you are doing anaerobic activity. You don't have enough oxygen. But if you can talk during activity, that tends to be aerobic activity. And as a last resort, that is how I'll educate them on what their intensity level should be. And we talked about the dyspnea, fatigue, and S3 heart sounds. So that is all of congestive heart failure. Thanks.